All right. Good morning, everyone, and welcome to Child Ground Rounds. It's my pleasure to introduce this morning's speaker, Dr. Joseph O'Neill, who's a professor in the Division of Child and Adolescent Psychiatry at UCLA. Dr. O'Neill's research spans over 25 years and focuses on MRS and EEG studies of the brain in psychiatric and neurological conditions. He has collaborated in first ever studies of MRS in stuttering, dysthymia, and trichotillomania, and his work has been central to models of ASD, OCD, and ADHD. Dr. O'Neill will be talking about neuroimaging studies in FASD this morning. Please join me in giving him a warm virtual welcome. And with that, I'll turn it over to him.
Okay. Thank you, Tara, for that lovely introduction. And here we go. Okay, so we'll be talking about neuroimaging studies of FASD. As you heard, we'll do about 10 minutes background on FASD, and then just very briefly, neuroimaging background, about 5 minutes on magnetic resonance spectroscopy, MRS, and diffusion tensor imaging, DTI, which we're using to study FASD. And then most of the time we'd like to spend talking about some recent FASD neuroimaging studies we've been doing here at UCLA, and then maybe we'll have 5 minutes or so for questions at the end. So here we go, FASD background. I've got some terrific slides here that Mary O'Connor has lent me. She's the real expert and authority on FASD here. The first one is on drinking among women. About 50%, over 50% of women of childbearing age in the US drink alcohol, and 75% of young women. 65% of pregnant women report drinking during the last 12 months prior to pregnancy. And that includes that crucial month or time between conception and when the mother discovered that she was pregnant. You can also induce FASD in that crucial period. 20% of pregnant women report drinking in the first trimester, and 10% report binge drinking. In the later trimesters, the numbers are lower, but still, unfortunately, not zero. So can we trust these mothers when they report whether they drank during pregnancy and the amount that they drank? Well, this slide compares the mother's word to laboratory findings. It summarizes studies where investigators surveyed the mothers as to whether they drank or not during pregnancy and compared the answers to objective biomarkers, essentially breakdown products of ethanol. And what you can see here in the two rightmost columns, the admitted percent versus the objectively determined percent. In every case, it was much higher for the objectively determined, twice as high, 5 times as high, 20 times as high as for the admitted drinking. So the issue could be more serious even than we thought. Incidence of fetal alcohol syndrome, that's the full syndrome, is 2 to 7 per 1,000 live births in the US, but that's only the tip of the iceberg. By conservative estimate, 5%, that's 1 in 20 of US children have neurodevelopmental problems associated with prenatal alcohol exposure, PAE. And 33%, and 1 1/3 of child psychiatric inpatients were found to have prenatal alcohol exposure. Of those, 1/4 had the full FAS syndrome and had never been diagnosed. 80% of children in foster care are found to have PAE. So fetal alcohol spectrum disorders are highly underdiagnosed. Nationally, only 11% of children with FASD are diagnosed before age 6, and 80% are never diagnosed in later childhood. So these are alarming statistics. So what can we do about it? Well, one way would be diagnosing more cases. How do you diagnose fetal alcohol syndrome? Here are the criteria for the full syndrome. There are 4 of them. The first is a pre or postnatal growth deficiency. The patient has to have height and or weight less than or equal to the 10th percentile for his or her age. The second criterion is a specific pattern of facial features. This is the so-called facial dysmorphia or the facial stigmata of FASD. It includes 3 main features: short palpebral fissures, that's basically the width of the eye slit, a flat philtrum, and a flat upper vermilion border. You need 2 or more of those to meet this criterion. And here's a cute little kid, a young child with FAS, and looking at the width of his eyes, that looks kind of normal to me, but you'd actually have to measure it. But if you look at the philtrum is that indentation in between your nasal septum and the top of your upper lip. In him, it's very flat, practically non-existent. So that is a qualifying feature. The third one of these 3 facial features is a flat upper vermilion border, basically the upper lip, whether the upper lip is curved or flat, and for this child, it's quite flat. So he would have 2 or more features. He would meet this criterion. The third criterion is central nervous system dysfunction. You need 1 or more of the following: either structural dysfunction, neurological dysfunction, or functional dysfunction. The structural dysfunction can be proved. One easy way of proving it is to simply measure the child's head size. If the orbital frontal circumference is less than or equal to the 10th percentile, that qualifies as structural dysfunction. And there are other ways to meet that too. For example, findings on an MRI of the brain. Neurological dysfunction could be things like seizures or central hearing loss, among many others. And the functional dysfunction includes a number of things, cognitive deficits, language problems, or in our case, if you can diagnose a psychiatric condition, that qualifies as functional dysfunction. Finally, to clinch the diagnosis, you need evidence of prenatal alcohol exposure. Ideally, that is the mother itself admitting that she drank during pregnancy. But oftentimes she will not say that, or the birth mother is simply unavailable. Remember, a lot of these kids are in foster care. In such cases, you can rely on medical records, or if you have another informant, the grandmother, a brother, a sister, or someone who saw the mother drinking while she was pregnant, then you can have evidence of prenatal alcohol exposure. The quantity can be very small, something like 2 drinks over the entire course of the pregnancy. Unfortunately, even very small quantities of alcohol consumed during pregnancy could induce a fetal alcohol syndrome. So how do you measure the palpebral fissures and determine a flat philtrum and flat upper vermilion? Measuring the palpebral fissures is very easy. You essentially hold a ruler up to the child's eye and have him or her open his or her eyes all the way. Asking them to look up is one way to do that. And you measure from the endocantian to the exocantian. Then you look up on a chart and see if the child is less than or equal to the 10th percentile for the child's age. And for determining the flat philtrum and the flat upper vermilion, we have these lip philtrum guides. They run from 1 to 5. The low numbers correspond to deep philtra and curved upper lips. And then the higher numbers are the flat to non-existent philtrum and the flat upper vermilion. If you score a 4 or 5 on the chart that qualifies for FAS. And we have one chart for Caucasians, one for African Americans. You have to remember, you have to have 2 or more of these features to qualify for FAS. Here are some children down here who have FAS. It's been said that children with FAS resemble each other more than they resemble their own unexposed siblings. And you can see that across races and ethnicities, a kind of similarity in these facial features. Here are the different diagnostic categories along the fetal alcohol spectrum. The first one we talked about already, that's the full-blown fetal alcohol spectrum, fetal alcohol syndrome, FAS. For that, you need the growth criterion, the facial stigmata, and CNS dysfunction. The second one, this is kind of an order of severity here. The next one is partial fetal alcohol syndrome, PFAS. For that, you only need the face and the CNS dysfunction. The third, least severe, is alcohol-related neurodevelopmental disorder, ARND, and for that, you only need CNS dysfunction and evidence of alcohol exposure. And here we have pictures of some kids who meet each of these categories. So psychiatric disorders, that would be something very important for us. This is the reason why you might see some of these children in your practice. We have a huge 87 to 90% of individuals with prenatal alcohol exposure who have a psychiatric disorder. That includes externalizing disorders, prominently ADHD, but also conduct disorder and oppositional defiant disorder, as well as internalizing disorders, anxiety disorders, depression, even bipolar. You could very easily misdiagnose a child as having idiopathic ADHD if you're not looking for the FAS, if you are not checking the growth, the facial stigmata, other CNS dysfunction, and inquiring about alcohol use. That's the most difficult one to ask. The other criteria are relatively easy to establish. Weigh the kid, measure the head circumference, and so on. The hard one is popping the question to the mother. So can we treat these children with medications? Sometimes medications are effective and sometimes they're not. I just checked yesterday, and still there are no large controlled randomized studies on the effects of medications on individuals with FASD. So that is a huge gap in our research that needs to be filled. Meanwhile, several clinical reports suggest that children with FASD, with ADHD and FASD, do not respond well to stimulant medications. They experience an increase in excitation and excitability instead of the pathological calming, not pathological, paradoxical calming that you want. So what do people do? They increase the dose, but in these children, the dose can be adjusted upward, often to no effect. So what do people do? Well, they add, they put on more drugs, which may also not work. And it's very typical for children with FASD to be on multi-drug therapy. For example, an inpatient study of alcohol-exposed children found 75% were on 2 or more psychiatric meds, compared to 43% of unexposed inpatients. So some depressing statistics that we looked at, however, that's a bit more optimistic. There are some promising treatment approaches in the preclinical realm right now. Antioxidants may decrease or prevent ethanol-induced apoptotic cell death in the cortex in mice. Lithium may prevent neuroapoptosis in the infant mouse brain. Choline supplementation has generated great excitement in recent years. It seems that it reduces severity of ethanol-reduced hyperactivity and learning deficits in these animal models. And later we'll see there are also human trials ongoing the past few years. And finally, forced training of a complex motor skill learning task can induce synaptic and dendritic modifications in the cerebellum and motor cortex of exposed young animals. And even more promising are the behavioral studies that have positive outcomes. 12 such behavioral regulation studies, 5 social skills studies, 9 parent education studies, and 1 alcohol misuse studies. Some of these studies, social skills and alcohol misuse, are being done right here at UCLA. So that was FAS. Let's talk even more briefly about neuroimaging, just for those of you who don't have the background. We used 2 neuroimaging modalities, magnetic resonance spectroscopy, MRS, and diffusion tensor imaging, DTI, to study FASD. Magnetic resonance spectroscopy, MRS, measures the levels of key biochemicals, the so-called metabolites in the brain region, and that tells us about the metabolic state of that region. Diffusion tensor imaging, DTI, measures how fast water molecules diffuse through a brain region, particularly white matter, in multiple different directions, which allows us to calculate the fiber direction within the white matter and evaluate the tissue integrity. To do MRS, you pick a volume of the brain, the structure in the brain that you're interested in. In this case, it's the pregeneral anterior cingulate cortex, the PACC. And at the MRI console, this is performed just like DTI at a regular old clinical MRI scanner. You place a little cube, this is called a voxel, a volume element, on the MRI in the structure that you're interested in. And then the scanner transmits electromagnetic signals into the voxel. It transmits them across a wide range of frequencies, and then it shuts itself off and switches itself over to a receiving mode. Now, the metabolite molecules inside the brain, each of them is like a little antenna, and each one is tuned to a different frequency that depends on the chemical composition of the model. It receives the signals only for its own particular frequency, holds on to them for a short time, and then transmits them back out. And the scanner, which is now in receive mode, picks up those signals. And as a result, we generate something called a magnetic resonance spectrum. And that's a plot of the intensity of the magnetic resonance signal versus the frequency. And it presents as a series of peaks. Each peak corresponds to a different metabolite at the metabolite's particular frequency. And the size of the peak is proportional to the number of metabolite molecules in the little voxel cube, which means it's proportional to the concentration of that particular metabolite in that particular brain region. 3 metabolites we're interested in for studying FASD are NAA, glutamate, and choline. The first is N-acetyl aspartate, NAA. It has a peak right here on the spectrum. And N-acetyl aspartate is highly abundant in neurons. It correlates with the density of the neurons inside the voxel. Therefore, it's thought of as a kind of neural marker. But it's also sensitive to the amount of activity that neuron is exhibiting. So it's a marker of neuron function, not just presence, but also function. NAA is in below normal amounts in several neurological disorders. It tends to increase in the course of brain development in maturation. Second metabolite that interests us is glutamate. It has some peaks along here in the spectrum. And glutamate, as you know, is the major central nervous system excitatory neurotransmitter. It's synthesized in neurons, although it's also present not just in the pericardia of the neurons, but in the axons. It's also a side reactant for the Krebs cycle, so it's involved in cell energetics, and is well known as an excitotoxin. Glutamate effects are under investigation in several psychiatric conditions: schizophrenia, ASD, MDD, and OCD. We've looked at all of these conditions with MRS. Finally, the choline compounds have a peak here on the spectrum, and these compounds are involved in phospholipid synthesis and degradation. So that's reflecting the synthesis and degradation of cell membranes. And accordingly, there are choline increases in several conditions involving excess synthesis or degradation of membranes, brain tumors, MS, stroke, inflammation, and so on. And in a few circumstances, you can also have choline decrease. On to diffusion tensor imaging, DTI. If you've ever looked at specks of dust in a sunbeam, then you've seen diffusion. That random floating around aimless motion of the dust specks is diffusion. Water molecules do the same thing. They diffuse through brain white matter, just like the dust motes in air. And DTI is an MRI pulse sequence that was invented that measures how fast this water diffusion takes place. And if we look at the cartoon over on the right here, we can understand this process a little better. Diffusion is different in isotropic media versus anisotropic media. An isotropic medium is a medium that has the same properties in all directions. That's supposed to be represented by this ball here, like a glass of water sitting on the table. The water molecule doesn't care if it diffuses up or down, left or right, or forward or backward. It's the same properties in all directions, the same rate of diffusion in all directions represented here. However, if we have something like this structure over here, a series of tubes, you can see the tubes block the diffusion of the water molecules. So the diffusion goes faster in the direction of the tubes, both inside and out, and inside the tubes in between. And it does not go very fast at all going across the tubes. Brain matter, white matter, is anisotropic. It's just like this system of tubes we were just looking at. Those would be like the nerve fibers that run through white matter, and the water molecules diffuse more easily along the fibers than across the fibers. And DTI scans each voxel repeatedly. DTI has voxels, the little cubes, just like MRS does. It scans each voxel repeatedly in different directions to measure how fast the water diffusion rate is in each direction. And if you look at all those data together, you can assemble and estimate what direction the fibers are running inside the voxel, and thereby you can characterize the properties of the tissue, the white matter tissue properties. And we characterize those properties with 4 commonly used DTI indices that we calculate out of the diffusion rates. The most popular one is fractional anisotropy, FA. That's a number that varies between 0 and 1, and it indicates how uniform the fiber directions are inside the voxel, how anisotropic the medium is. If FA equals 0, the fiber directions are completely random. It's a fully isotropic medium, like that little ball that we saw on the last slide. And if FA is equal to 1, that means that all the fibers in the voxel are pointing in the same direction. That's a fully anisotropic medium. The properties are highly dependent on the direction. Now, FA tends to increase as white matter matures in children. It's lower for low fiber densities and low myelination of the white matter. So roughly speaking, for white matter, high FA is considered good, low FA usually considered bad. The second DTI index is the mean diffusivity. MD. That's kind of a bulk measure of the diffusion coefficient, the diffusion rate averaged across all the directions in the voxel. High mean diffusivity corresponds to a medium that's more aqueous, more water-like, that has faster water diffusion. So edema has high mean diffusivity. CSF, which is almost pure water, has very high mean diffusivity. Low MD mean diffusivity corresponds to a medium that's more hydrophobic, like a liquid, less amenable to passage of water. MD decreases with maturation as myelin develops, and is higher for developmental defects. For white matter, high MD is usually thought of as bad, low MD usually thought of as good. Two other indices, the axial diffusivity AD and the radial diffusivity RD, and those are basically the diffusion. AD, axial diffusivity, is the diffusion coefficient, the diffusion rate in the principal fiber, along the principal fiber direction in the voxel, e.g. along the axons inside the white matter. High AD again corresponds to a medium that's more aqueous, faster diffusion along the axon. That could happen if, say, the spaces between the adjacent axons are loosening up, allowing more extracellular fluid in there. AD is higher near axonal damage and fragmentation. For white matter, high AD usually thought of as bad, low AD usually thought of as good. Radial diffusivity, on the other hand, is the diffusion rate perpendicular to the fiber direction, e.g. crossing through the myelin. High RD corresponds again to a more aqueous medium, faster diffusion going across the myelin. That could happen, for example, if the myelin sheath is underdeveloped or loosening up. RD is higher for demyelination and dysmyelination and for thinner axons. And again, high RD is thought of as bad, low RD is as good. Here's some maps of the DTI indices from our study of FASD, which we are coming to that study now. This study was concerned with the differential diagnosis of ADHD in the presence of prenatal alcohol exposure, ADHD plus PAE, compared to ADHD in the absence of prenatal alcohol exposure, ADHD minus PAE. And we're trying to do this with the help of neurobehavioral metrics and also MRS and DTI of the white matter. So the FASD ADHD differential diagnosis is a big deal, as we've already alluded to. There's a very high incidence of ADHD in FASD, but FASD is not often tested for in ADHD patients. Therefore, ADHD due to FASD can often be misdiagnosed as ADHD from a different etiology, e.g. familial ADHD. And neuroimaging studies of ADHD almost never screen for FASD, which means that their samples may well contain patients who have occult FASD in them. So these past couple decades of neuroimaging research that we've done on ADHD, some of those, the validity of some of those findings might be put in question. But more importantly, the clinical significance is that, as we said, ADHD and FASD often responds poorly to stimulants, whereas ADHD minus PAE will probably respond better to stimulants. And FASD often has worse long-term outcomes than ADHD minus PAE. As you know, about 50% of ADHD patients grow out of it, sometimes even without treatment. Not so for FASD. There are high rates of mental illness, disrupted school, legal troubles, substance abuse, and suicide in adolescence and then in adulthood in these patients. So you want to know have a better idea what the long-term outcomes are for your patients. Also, ideally, our research would like to kind of creep towards an objective diagnosis of cases of FASD in the absence of informants or facial stigmata. Like we said, you can't always find the birth mother, and not all the forms of FASD require the facial stigmata. This slide will skip. And so there are prior neurobehavioral findings relative to ADHD plus PAE versus minus PAE to guide us, to guide our study. For example, the mix of hyperactive, impulsive versus inattentive symptoms might be different in the two ideologies. This can be assessed easily with very standard clinical instruments like the Conners Behavioral Rating Scale. Most studies have found greater inattention relative to hyperactive symptoms in ADHD plus PAE. However, one recent study found the opposite. They found more hyperactivity in the ADHD plus PAE patients. Also, executive dysfunction is common in both ADHD and FASD, and it may also be able to distinguish between the two etiologies. So we're asking, in particular, using the Dellis-Kaplan Executive Function System, the DKEFs. So we're asking in our study if we can distinguish ADHD plus PAE from ADHD minus PAE using the Conners and the DKEFs. There's some prior MRS findings in FASD to guide us. People have found effects involving NAA, glutamate, and choline. With respect to choline, we did a pilot study that found lower choline in ADHD plus PAE than ADHD minus PAE in one white matter tract, the anterior corona radiata, ACR. And as I mentioned, there are human trials of clinotherapy, choline dietary supplementation for FASD. Most have had some positive results. A few have had negative results. And in ADHD, there are also been seen MRS effects involving NAA, glutamate, and choline, sometimes in white matter, but none of these studies ever screens for FASD, as I said. So we asked if we could distinguish ADHD plus PAE from ADHD minus PAE using NAA, glutamate, and choline. And then finally, there are prior findings with DTI in FASD. Low white matter FA was observed, low fractional anisotropy. And our pilot study also observed lower fractional anisotropy in ADHD plus PAE than ADHD minus PAE in the anterior corona radiata. Other studies have found high white matter, mean diffusivity, axial diffusivity, and radial diffusivity in FASD. And there have also been abnormal DTI findings in white matter in ADHD, including low FA in many tracts, and surprisingly low MD. The low MD is supposed to be good, but low MD has been found in multiple white matter tracts in ADHD. But again, very few of these studies screen for prenatal alcohol exposure. We asked if we can distinguish the two etiologies using these 4 DTI indices. Okay, so here's our subject sample. We had 23 children with ADHD plus prenatal alcohol exposure. They averaged about 9.7 years old. Unfortunately, that was a year or two younger than the other two groups. So therefore, we used age-corrected or age-normed variables for all our statistical analyses. And there were 19 children with ADHD minus PAE. Notably, these were all familial, presumptive familial ADHD, which means that we had one or more first-degree relatives with a confirmed ADHD diagnosis. And then finally, 28 typically developing healthy controlled children. And so we acquired magnetic resonance spectroscopy from an area that we called supraventricular white matter. It's the white matter that's high up on the brain. Here's an axial MRI. We can see there's a nice big swath of white matter here that we sampled with magnetic resonance spectroscopy. We used a variant of magnetic resonance spectroscopy called magnetic resonance spectroscopic imaging, MRSI. And in that form of MRS, you don't acquire the data from just one voxel, one little cube. You acquire it from a whole array of cubes simultaneously. We also acquired DTI from the entire brain, but we analyzed the DTI indices in the very same white matter here from which we acquired the MRS. Okay, and there we are. So some of our results here. First, just looking at the Conners hyperactivity impulsivity scale, we found that the children with ADHD plus PAE, the red circles here, had significantly higher hyperactivity impulsivity than the children with familial ADHD here. And of course, both groups by design had much higher hyperactivity than the healthy control, typically developing children there. So an MRS finding was that there was a difference in the glutamate levels between ADHD plus PAE and ADHD minus PAE. Thereby, interestingly, the glutamate levels were lower in the familial ADHD than in the PAE ADHD or than in the typically developing children. And then finally, a DTI result, the mean diffusivity was higher in ADHD plus PAE than it was in ADHD minus PAE. And again, the values in ADHD minus PAE were lower than they were in the typically developing subjects. Okay, so by way of interim comment, so we've seen a couple significant between group differences in single measures, typical sort of thing you'll see in neuroimaging psychiatric papers, but there's lots of overlap between those groups, between the circles and the triangles and the diamonds. And overlap is bad for single patient classification. So we asked ourselves, therefore, would composite measures yield a better separation between the groups than these single measures? And if you're putting composites together, combining the different variables, multiplying them together, would perhaps then metrics that have modest or even trend level between level differences alone might yield bigger differences in combination. And as we just mentioned, our MRS and DTI metrics happen to have been evaluated in identical overlapping volumes. That's not typical for neuroimaging. Most studies calculate MRS and DTI in separate anatomical volumes where the overlap between the two is often partial at best, but our overlap was very high between those volumes. So that's kind of an ideal scenario for calculating MRS DTI composite variables, something like multiplying the glutamate times the AD times the RD, because all these are being acquired in the same volume of tissue. So we compared the classification of subjects into ADHD plus PAE and ADHD minus PAE using neurobehavior alone, only neuroimaging, the MRS and the DTI together, and neurobehavior plus neuroimaging. We did this using receiver operator characteristic ROC analysis. A lot of you are probably familiar with that. It's the simplest, the most old-fashioned method of classification. And here's some of our results. In ROC analysis, you're plotting sensitivity versus 1 minus the specificity. You're classifying the patients into the two different categories, and you're seeing basically how accurate was your classification, how many true positives, how many false negatives, and that sort of thing. And sensitivity and specificity both run from 0 to 1. So this cube here would be, the area of this entire cube would be 1 times 1. It would be equal to 1.0. And we're looking for the blue receiver operator characteristic line. We want it to have the maximum possible area underneath it, whereby an area of 50%, 0.5 would be this red line. That would be just a random classification. We're hoping to get above random. When we use the Conners scale itself, the Conners hyperactivity impulsivity, we got an area under the curve of 0.7, which is a significant classification, but is only considered fair. Greater than 0.70 is only fair by the standards of ROC. So then we looked at neuroimaging alone. In this, for example, the metric glutamate times AD times RD, well, that achieved an AUC of 0.84, which was highly significant and which qualifies as a good separation of the two groups. And you can see it has a much bigger area under the blue curve here. Finally, we combined neuroimaging and neurobehavior with this complicated metric here, glutamate times AD times RD divided by NAA and divided by FA, and then times the Conners hyperactivity. And that yielded area under the curve of 0.92, very significant, and that qualifies as a very good classification. And a very big area under the curve there, we were quite pleased with that finding. You can plot these data in a different way. This is just that variable that we were just looking at, the composite variable. And for all the individual subjects, for the three groups, and if you draw a line here, the dashed line, everybody in the ADHD+PAE group is above that line. Only two subjects with the familial ADHD are below or are above that line. Everybody else is below. Only two healthy controls are above that line, are typically developing subjects. Everybody else is below. That corresponded to a sensitivity of 100% and a specificity of 82%, which is considered pretty good, starting to get used to something that might be practical, that might be practically useful. We performed a kind of cross-validation in quotation marks because for true cross-validation, you have to get a separate group from the outside world and retest them. We didn't have that, so we split our existing group in two and repeated the procedure. And for subgroup 1, we had area under the curve greater than 0.8, considered good. And for subgroup 2, area under the curve greater than 0.9, very good. And we also looked at this with more advanced classification algorithms, something like machine learning, but a special kind of machine learning that's designed for groups of this relatively small size, 20, 30 patients. And that yielded 83 to 95% diagnostic accuracy, classification accuracy using the glutamate-based variables, and indicated that glutamate and the mean diffusivity and the Conners hyperactivity were key discrimination variables. Shantanu Joshi from neurology helped us with these sophisticated analogies. He's part of our FASD team. So to discuss these points, these findings, we had higher Conners hyperactivity, impulsivity, and ADHD+PAE than ADHD-PAE. That disagrees with some of the prior studies, but it does agree with the most recent study. And the disagreement with the prior studies might have to do with the fact that our ADHD-PAE group is all familial ADHD, whereas the other studies did not make that distinction that I'm aware of. We saw lower glutamate in ADHD-PAE than in the other two groups. This actually agrees with prior findings of low glutamate in ADHD and supports hypoglutamatergic models of ADHD that people have advanced. And we saw a higher mean diffusivity. Also, we didn't show it, but higher axial and radial diffusivities in ADHD+PAE than ADHD-PAE. This agrees with prior findings of high mean diffusivity in FASD, suggests maybe you have fewer and thinner axons and maybe dysmyelination in white matter in FASD. The finding also agrees with prior findings of low mean diffusivity in ADHD. And I'm not sure how to explain that exactly. Perhaps you have some aberrant or compensatory overgrowths, for example, of unmyelinated axons. They're thick, but they're unmyelinated. Something like that might produce that kind of finding. Hyperactivity and impulsivity was a fair classifier of the two ADHD etiologies. And So standard clinical instruments are such as the Conners used to diagnose ADHD. They may be good for that purpose, but alone they may not be good enough for this kind of differential diagnosis. MRS and DTI combined yielded a good classification of these two conditions. So normal neuroimaging alone is maybe promising, but still under the AUC equals 0.9 ambitious threshold that we would like to meet. Finally, when you put the behavior and the MRS and the DTI all together, you get a very good classification of these two conditions, and whereby glutamate, MD, and Conners hyperactivity were key factors. Choline-based variables, even though they're important for the clinotherapies, they only had AUC greater than 0.8. They didn't make that 0.9 cutoff. At any rate, with further refinement, maybe we can eventually reach some clinically useful classification algorithm. Many various limitations to the study, sample size modest, we're talking 20, 30 patients, or less than that, 10, 20, 30 patients per group. The ADHD+PAE group was significantly younger, but we did use the age-corrected variables throughout. We had more medication use in ADHD+PAE than the ADHD-PAE, very typical, as we said at the beginning of the talk. Subjects were asked not to take, most of them who were on meds were on stimulants. They were asked not to take stimulants on the testing days. Maybe that helped mitigate that factor. There was exposure to other teratogens in the ADHD+PAE group. That's hard to avoid in this kind of work. It's very typical. If you had drinking during pregnancy, you may have smoking. During pregnancy, you may have marijuana. You may have other drugs, but the degree of it was rather less in our sample than in many other published studies. And then we had some strengths in our study, all familial ADHD-PAE, few comorbidities in the sample, surprisingly. No adolescent subjects. These are all children 8 to 10. Many other imaging studies mix children and adolescents, and then various technical strengths. In conclusion, hyperactivity, impulsivity may be higher in ADHD+PAE than in familial ADHD-PAE, and glutamate, MD, AD, and RD may be higher in ADHD+PAE than ADHD-PAE in the supraventricular white matter, and combined neurobehavioral plus MRS plus DTI measures may effectively classify individual patients with these two ADHD etiologies. And so here's our UCLA FASD research team. And I'd like to mention our NIH funding from NIAAA. We have Drs. Levitt and O'Connor have an R01, and previously Dr. Levitt had an RC1 from NIMH. Thank you very much for your attention. Okay, so maybe I should stop the share. Okay.
All right, thank you very much, Joseph. That was a wonderful talk, and I think we have a couple of questions that have come in already. The first is from Dr. McCracken, and he asks, is there any relationship between glutamate and cognitive profiles or behavior?
For this particular sample, I don't know. We've written a couple manuscripts on this, and we do have some correlations with some of the MRS and DTI variables, but I couldn't cite them for you offhand. So nothing dramatic, let's put it that way, that's stuck in my mind. But that can be further investigated. We have lots of clinical and neurobehavioral data on these subjects.
Right, terrific. The next question comes from Dr. Barnett, and he asks, do you have any good non-judgmental ways to ask parents about substance use during evaluation?
Okay, it would be a great question for Dr. O'Connor, but I would hazard Well, it has one sort of way of cheating is to kind of do it just with a written form that you can slip to them. Another thing to keep in mind is that sometimes you don't always get as strong of an emotional reaction as you feared when you asked these women. A lot of times these women, they already know themselves. They know it directly, or they sense it. They kind of figured it out in their own mind, even if they haven't told anyone about it or admitted it to anyone. So it's definitely worth taking the chance. It may not be as scary to ask the question. It may not be as scary as you have thought. Good approach can be just to be very matter of fact about it. Okay, any problems with you, any difficulties during your pregnancy? How long was it, and so on? And did you consume any alcohol during the pregnancy? Did you perhaps smoke during the pregnancy, cigarettes? Any other substances, marijuana perhaps? These would be some of the approaches, but I would definitely defer to Dr. O'Connor on the way to manage that.
I agree that Dr. O'Connor is our resident expert in this. And I hope I'm remembering correctly from my own training with her, but I've always, just to add to what you said, Joseph, I've always tried to inquire more broadly about lifestyle factors, just trying to kind of create an opening for understanding, in general, do you smoke or do you drink? What does that look like for you typically? And just kind of on an average day or week, what might that look like? And then asking, how was this a planned pregnancy? How far along were you before you realized? And that way you can start to get a sense of some things that might be harder to segue into otherwise. But that might be another way to create an opening.
That's great. Great. Thanks for saving me on that one there. Yeah, that's very good. Starting out with the general lifestyle, and then did you also smoke during pregnancy? This type of a thing, and also, oh yeah, I did want to mention that a lot of the subjects we recruited, the exposure occurred in that critical zone between conception and discovering the pregnancy. And that's when it happens a lot. And it's also lower shame for the woman if it's during that time, because she didn't know.
Yeah. We'll give an opportunity. I don't see any other questions in the Q&A box, but maybe we'll give another minute in case anyone else has a question they'd like to ask Dr. O'Neill.
Of course.
Oh, and here we go. Dr. McCracken is interested in challenges related to imaging this group of kids, and that's an excellent question, given the constraints of imaging and the nature of this patient population.
Right, yeah, because they can be little squirmers. They're not keeping still in the MRI scanner. At least that's what people imagine. But if there's anything that the history of MRI scans of ADHD has proven over the past 10, 20 years is that you can scan these kids. A lot of people think that you can't, but you definitely can. And there are studies with hundreds, and we've had studies with hundreds of ADHD kids before. And part of it, I'm just talking about the MRI scanning, part of it is to, we do a lot of training and sensitization to the scanner. So it's not a surprise for them, it's not as scary. And they watch a movie, typically a child's film, during the scan. And that's been a real godsend to us, because it really captures the child's attention, and they can even forget that they're there, and it's not as scary. anymore. And that's also typical of ADHD. When they're dealing with something that's egosyntonic or something that's pleasurable, they can actually focus quite well. But if it's something that they're not as interested in, doing homework or that kind of a thing, that's when the issues with distractibility and so on set in. So if they're watching the movie, that's fun, right? That can keep their attention. So the challenge, and with FASD, it's been about the same. It's not as scary as you might think that it is.
That certainly makes a lot of sense, that if you can engage them, you're going to have better rates of success. I find myself with a question, a broader one. Oh, I actually see one pop up from Mary. Mary is giving us some guidance on how to assess. She says, ask 2 time points before the woman realized she was pregnant and after she found out she was pregnant. Prior to recognition correlates highest with negative outcomes, including the face. Don't ask how much, don't ask, did you drink, but rather ask, how much did you drink?
Ooh. Ooh.
Pearls of wisdom.
Yeah,
Thanks,
good
Mary,
thing
for
we've
saving
got
us
Mary
both.
on board. Yeah, I also wanted to mention, in scanning these children, it's a good idea to do it later in the day when they're tired, and you ask the parents to take them out to the playground or something, have them running around, to the beach or something, so that they're all tired and run down. If they fall asleep in the scanner, that's a good thing. We can get cleaner data that way.
I was also struck by your all-star lineup of a team. I know in my own work, our rates of data loss have varied wildly based on how familiar the team was with working with our patient population. And we've, had really successful runs and really challenging runs, but clearly you guys have been to this rodeo. We are, I think, just about at the hour. So if there are no further questions, I think we can wrap it up there. But thank you, Dr. O'Neill. I assume slides are available for people who want them, and people can inquire with Rima.
I can make them available, whatever the standard procedure is. I'm happy to make them available.
Terrific. And I think for those who are interested in further FASD resources, please, you can reach out to me directly, and I'm happy to coordinate through Mary and the rest of the research team. But thank you all for attending, and thank you, Dr. O'Neill, for a great talk.
Okay, thank you.
Take care.
Bye, everybody.